Oh, sir, is my screen visible?
Yes, yes.
So, can I start, sir? Hello?
Yes, you can start.
Okay, okay, sir. Um,
Others in the room can disconnect their audio so they can just see the presentation.
Good morning, everyone. Today's topic of discussion is retinoblastoma. So, it is primitive neuroectodermal tumor, most common primary intraocular malignancy in children, and average age at which the child present is 18 months. If we look into the data, 5,000 to 6,000 new cases every year is in the world, and out of which 1,500 to 2,000 new cases are in India. Out of that, only one third reach to the tertiary center. Rest of them managed either in the secondary center or primary center by enucleation or by the conservative management. So the mortality rate in India is very high, up to 50%. So it's a deadly tumor here. Whereas in developing countries, early diagnosis and improved protocol-based treatment convert the scenario from 95% mortality to 98% survival over the past 50 years. Coming to the genetics, so RB1 gene is the tumor suppressor gene that is located on long arm of chromosome 13, whose mutation predisposed to the retinoblastoma. And mutation in both the allele is required for the development of retinoblastoma. So we have two kind of mutation. We have hereditary germline mutation and we have non-hereditary somatic mutation. So Knudsen gave the two-hit hypothesis, which states that of in germline mutation, offspring get one mutated allele from the parent, and that one pair of allele remain mutated in all the cells in the body. And during the second hit mutagenic effect, the second allele also get affected and undergo malignant transformation. So since mutation present in all the cells, so bilateral cases, multifocal tumor, non-ocular tumor like pineoblastoma, osteosarcoma, soft tissue sarcoma, melanoma, they tend to occur more in the germline mutation. Whereas in the non-hereditary somatic mutation, both the hit occur together. Tumor is unilateral, non-transmissible, and not predisposed patient to non-ocular tumor. Here, risk in the siblings and offspring is about 1%. Coming to the clinical feature, so leukocoria is most common sign and symptom and the earliest manifestation with which the child present to the OPD, and it is present in around 50% of patient. Patient will also have poor vision. Patient will present with the squint in 25% of cases due to sensory deprivation, and esotropia will be more common than the exotropia. Then patient can also be present with the redness. Now, in advanced cases, especially in India, what happened? Retinoblastoma becomes so enlarged that it outgrow the blood supply and goes into the spontaneous necrosis, which result into the sterile inflammation. And child present with the orbital inflammation which mimic with the orbital cellulitis. So when children present with the orbital cellulitis and fundus examination is not possible, it is advisable to do ultrasonography to rule out any calcific lesion of the retinoblastoma. In advanced cases, when the orbit got involved, got infiltrated, patient will present with the proptosis and rarely present with the fungating mass. Now, sometimes patient will present with the hypopion, which will simulate the uveitis. But as you can see, there is no circumciliary congestion. There will be no AC cells, no AC flare. There will be only hypopion. So this condition is known as white eye hypopion, and this is nothing but the tumor cell present in the anterior chamber, which is characteristic of retinoblastoma. Now, patient will also present with the hypema, as you can see in the first picture, and the vitreous hemorrhage, as you can see in the second picture. And this vitreous, along with the vitreous hemorrhage, you can also see the dilated retinal vessels. Now, some child present with the secondary glaucoma, which may be associated with the ophthalmos, enlarged cornea, and this will mimic the congenital glaucoma. Now, rarely patient present with the thysis bulbi, as we have already seen that there will be the spontaneous tumor necrosis in the advanced cases, which result into the inflammation and then which result into the ciliary shutdown and thus thysis. Now, how you will differentiate the child with thysis, whether it is due to the retinoblastoma or due to the conventional thysis? So on ultrasonography, if you see the intraocular calcification within the vitreous cavity, that means it is secondary to the retinoblastoma. Whereas in the other form of conventional thysis, which is secondary to the trauma, infection, dystrophic calcification, the calcification will be in the eye coat, in the sclera, in the uveal tissue, and not in the vitreous cavity. Now, coming to the type of tumor, so we have four clinical type of tumor. We have the endophytic tumor, we have the exophytic tumor, we have mixed configuration, which is more common, and then we have diffuse infiltrative tumor. So in the endophytic tumor, as you can see in the first image, tumor grow into the vitreous cavity with vitreous seeds and with the minimal or no subretinal fluid. As you can see in the third picture, the blue lining is the retina, and the tumor grow inside the retina into the vitreous cavity with the seeds. In the exophytic growth, as you can see in the third picture, blue is the retina and tumor goes outward with the subretinal fluid and with subretinal seeds. And clinically, it looks like the bullous retinal detachment. Now, third, we have the mixed configuration in which we have the component of both endophytic and exophytic growth, and it is most common. Then we have the fourth type, which is diffuse infiltrative type. As you can see in the first image, the retina is thickened with the infiltrative cells and there is no localized mass. And this type will manifest as the anterior chamber manifestation, like a patient will have hypopyon, vitreous hemorrhage, high FEMA, and uveitis like picture. Now, coming to the diagnosis, retinoblastoma diagnosis is clinical. So you can do the indirect ophthalmoscopy under anesthesia with 360-degree evaluation of ora serrata with indentation. You can also do the ultrasonography, where you can see the round or irregular hyperintense mass inside the vitreous cavity, and corresponding A scan corresponding to this calcification, A scan will show high spike that is similar to the scleral spike. Then we can also do the MRI and CT to rule out any extraocular extension to the orbit or optic nerve extension. Then to rule out any intracranial extension associated pineoblastoma. CT is not generally preferred because of radiation exposure to the child. Now, coming to the pathology, so tumor cells are the small basophilic cells known as retinoblast with large hyperchromatic nuclei and scanty cytoplasm. That means high nucleocytoplasmic ratio. And these cells grow around the feeding vessels. Now, as we described that they will undergo necrosis and calcification. So after that, they will stain pink or purple on H&E stain. So these cells grow in the sheets of undifferentiated cells, forming a characteristic pattern called the rosette. So if the rosette is present with an empty lumen, it is known as flexner winter-steiner rosette. If the ring of cell is present with an eosinophilic fibrillary center, it is known as Homer-Wright rosette. And in some cases, patient will have florates, that is known as these florates are highly differentiated cells. They lack the mitosis, they lack the necrosis, and they remain benign for the life and called retinoma or retinocytoma. Now, coming to the vitreous seeds, so how they form? They form either by break in the internal limiting membrane or by budding or sprouting process. So these cells, after going into the vitreous, they have capacity to grow by the clonal expansion. So they can grow either independently without depending on the substrate and grow into the vitreous. They form the free floating seeds, or they can grow, or they need a substrate, like they need retina, they need the epiretinal membrane to grow, which is known as adherence dependent growth, and they form the epiretinal seeds. Now, the OCD-based classification of retinoblastoma seeds, we have 7 types. We have the classic vitreous seeds, in which seeds present in the vitreous cavity. We have the prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal, and then we have the intracameral deposit. Intracameral, in the anterior chamber, deposition can be of two types: the deposition and the infiltrative. In the deposition type, cell will reach through the zonules into the anterior chamber and will deposit here, there, and in the infiltrative type, cell will go through the eye coat. That is, it will infiltrate the ciliary body, it will infiltrate the iris, trabecular meshwork, and then goes into the anterior chamber and deposit. Then we have the morphological classification of seeds also. First is dust type, where you have the minute dust-like particles. You will see the minute dust-like particles. Then you have a cloud where you have a membrane-like material, and then you have a sphere where you have a large globule-like material. And then we have the mixed type where you see all the three components. After treatment, these vitreous seeds regress, and there is a pattern of regression which has a classification. So type 0, when the vitreous seed completely disappear. When it convert into the calcified seeds, they are known as type 1A. If it convert into the crystalline refringent dust, that is type 1B. If it convert into the amorphous non-spherical seeds, that is type 2. And if they have combination of these seeds, that is type 3. Now, classification, there are two ways to classify the tumor. First is tumor staging and second is tumor grouping. So tumor staging has the survival as the outcome, whereas in the grouping, we take eye salvage, preservation of eye as the outcome. So first, in the staging, we have international retinoblastoma staging system. We have 4 stages. In stage 0, there is no enucleation. In stage 1, there is enucleation and tumor is completely resected without any microscopic residual tumor. If there is microscopic residual tumor, it will come in stage 2. And stage 3 will have the regional extension to the orbit, to the regional lymph node. In stage 4, the tumor is metastasized through the hematogenous route or to the CNS extension. So up to stage 3, the prognosis is really good. There is 95% survival rate, whereas in stage 4, the survival rate drastically decreased to 5%. Then for the tumor grouping, we have international classification of retinoblastoma. We have 5 group. In group A, when the tumor is small, less than 3 mm, comes in group A. When the tumor is large, more than 3 mm, comes in group B. Also, any size of tumor, it is present near the macula, juxtapapillary location, or it have the subretinal fluid within 3 mm of its margin, will come in the group B. Then if tumor has seeds, and that seeds can be subretinal or vitreous within the 3 mm of tumor border, that comes in category C. And if the seeds is distant, diffuse, more than 3 mm from the tumor border, it will come in the category D. In the category E, group E, we have the advanced retinoblastoma, like extensive retinoblastoma that occupying more than 50% of globe. If there is any neovascular glaucoma, if there is any opaque media from hemorrhage in anterior chamber, vitreous or subretinal spaces, or if there is invasion of the postlaminar optic nerve choroid of more than 2 mm, if there is involvement of sclera, orbit, anterior chamber, etc., that all will come in the group E. What new in the staging is TNM8 staging given by American General Committee of Cancer. So it is similar to other group of cancer in the body. T1, it will involve T1 when the retinoblastoma doesn't have seeds, T2 when it has seeds, T3 correspond to the group E of tumor grouping, and T4 whenever there is extraocular invasion. But what new is this AJCC included the H trait also in the TNM8 staging. So it is TNM-H staging where heritable trait is taken as a component. Coming to the treatment, like other cancer, we have a goal of management in a line. So first is salvage of life, then we have salvage of organ, in our case salvage of eye, and then we have salvage of function. So we have three management option for the intraocular retinoblastoma. First is focal therapy, which include the cryotherapy, laser photocoagulation, thermotherapy, plaque brachytherapy. Then we have the local therapy, external beam radiotherapy, enucleation, and then we have the systemic therapy, that is chemotherapy. So cryotherapy is a high cryotherapy, that is triple freeze thaw technique, in which, as you can see in the first picture, this is we took the 3 mm cryo probe and is indented on the area of tumor. As you can see in the first picture, this is indented tumor in a way that tumor is centered on the probe, and then you freeze the tumor thrice and then allow to thaw it spontaneously thrice. And you can see in the second picture the tumor is froze, and also you can see the 1 to 2 mm of vitreous haze, that is freeze vitreous component. So what is the indication? It is indicated in the small 2 to 3 mm of tumor located in the periphery. Why periphery? Because this cryotherapy causes the collateral damage and scarring. As you can see in the first picture, this is the actual size of tumor, and after cryotherapy, the scarring become very large. So if the tumor is present at the equator or posterior to the equator, we doesn't advise cryotherapy. Other than scarring, it will also cause epiretinal membrane formation, dragging of retina, tractional retinal detachment, atrophic hole. Second is photocoagulation, where in which we coagulate the retina around the tumor cells. So principle is large diameter laser burn around the tumor in 2 rows. That will cut off the blood supply of tumor and that will replace the tumor. So it again can result into the large scarring. They occlude the blood vessels that passes through the lasered area. So it reduces the chemotherapy uptake also. Then there is a big scarring. So it will result into the visual field defect. The patient will have scotoma. Then photocoagulation will also result into the internal limiting membrane rupture and thus the vitreous seeding. So it is reserved. So it is not the primary modality and reserved for the condition where other modality not available. Now the transpupillary thermotherapy, this is the primary focal therapeutic modality, where the principle is you use the semiconductive diode laser and apply it directly on the tumor, and it will increase the intra-tumor temperature by 45 to 60 degree, and then the tumor undergoes slow apoptosis. So as it directly applied on the tumor, so there is less scarring, so it is safe where the tumor is close to the fovea or disc. Then we have the triple T plus, that is transpupillary thermotherapy plus, also known as endocyanin green enhanced triple T. So it is used in the patient who have recurrence, and if the recurred tumor present over the already scarred area. Because in the already scarred area, there is no pigmentation, so thermotherapy uptake will be less. And the wavelength used in the endocyanin green and diode laser has synergistic effect. It enhances the uptake of thermotherapy and result into the rapid regression of tumor. And it has been noted that this will cause 80% regression in the refractory tumor. So these are the focal therapy. Then in the local therapy, we have plaque brachytherapy. So it will use in the large tumor, which doesn't have risk to life, but risk to loss of eye and vision. So up to the tumor of 16 mm diameter and 8 mm thickness, we can use plaque brachytherapy. Commonly used are iodine 125 and ruthenium 106. So as you can see in the second picture, this will placed inside the extraocular muscle above the area where tumor is present and then sutured onto the sclera. So it will cause it will have 90% success rate, but disadvantage is it cause RPE atrophy and thus impaired the vision. So it is also not the primary treatment and used where chemo reduction failure is there, or if the tumor reoccur. Then we have the external beam radiotherapy. Earlier, it was used extensively, but now it is no longer used primarily because it has success is only group A, B, and C. D and E doesn't show much of advantage. Plus it has the radiation complication. They have radiation cataract, they have radiation retinopathy, papillopathy. They will also result into the phthisis bulbi and ocular surface problem. Above that, the most important is if we do the external beam radiotherapy in patient of age less than 12 months and bilateral cases, it will increase the incidence of second malignant neoplasm by 35%, whereas if not given, it will remain at 6%. Now, currently the most widely used therapy is the chemotherapy. We can give intravenously, we can give intra-arterially, we can give periocular injection, or we can give intraocular. So first is intravenous therapy. So how it help? It will regress the tumor and it will decrease the subretinal fluid. So you can give the secondary focal therapy to treat the retinoblastoma. So what is the protocol? You will give the carboplatin, etoposide, vincristine, 6 cycle, 3 to 4 weekly. And before that, you will give the chemocryotherapy. That is a small spot of cryotherapy at the periphery. It will disrupt the blood aqueous barrier and increases the intravitreal uptake of chemotherapy. And focal therapy you can give after 4 cycles. As you can see in the picture, first is the actual size of the tumor. It is involving the fovea. It is present in the macula, involving the fovea. And after the cycle, tumor has the tendency, when it regress towards its blood supply. So this tumor present over the superior temporal arcade will get its supply from the superior temporal artery, so it will regress towards it and makes the fovea clear. So after chemotherapy, we can give the focal therapy and treat this patient. In the advanced retinoblastoma, like in group D, in group E, alone standard dose chemotherapy will not help. You can either give the combination of high dose chemotherapy, like as you can see here, the carboplatin is 18.6 milligram per kg, etoposide 5 milligram, and vincristine 0.05 milligram. Here, high dose of these drugs like carboplatin 28 milligram per kg, etoposide 12 milligram, vincristine 0.025 milligram will be given along with the periocular injection of carboplatin or topotecan. Except that you can also give the intra-arterial chemotherapy also. In the intra-arterial chemotherapy, you catheterize the ophthalmic artery and deliver the drug directly into it. And it is the most effective for group D and E and for the larger recurrence, but the disadvantage is it is very expensive. So up to that, to conclude the treatment in group A, B, C, alone chemotherapy with the focal therapy will help, but in group D and group E, either you can give the intra-arterial therapy or intravenous therapy with the periocular injection. Now, how you treat the vitreous seeds? So if the vitreous seeds is present with the viable retinal tumor also, you cannot give the intravitreal injection. You have to treat it with the intravenous or intra-arterial chemotherapy along with the periocular injection. So you give the subtenon injection of topotecan or carboplatin. Whereas if there is only residual vitreous seeds and there is no viable retinal tumor, you can give the intravitreal chemotherapy. Indicated as malphilin has to be given, but in India or in the pigmented eye, this malphilin will cause the RPE, dystrophy, uveitis, cataract. So here, topotecan is preferred 30 microgram 3 weekly. In the refractory cases of vitreous seed, the combination of topotecan and malphalan can be given. If there is the vitreous seeds in the anterior chamber, like in the first picture, this depository intracameral seeds which come through the zonules, intracameral chemotherapy topotecan 5 microgram can be given. But if the deposits is infiltrative, like it infiltrate the iris, as you can see in the second picture, the iris is infiltrated and this become D-shaped. So infiltrated intracameral seeds need enucleation. Now, enucleation can be advised and is the treatment of choice in the advanced unilateral group E, anterior segment infiltration. If there is anterior segment infiltration, if there is ciliary body infiltration, if there is high FEMA, vitreous hemorrhage, or neovascularization or inflammation. So it has been noted that neoadjuvant therapy before the enucleation doesn't give any beneficial result. Few points to be noted at the time of enucleation. So minimal manipulation is required to avoid accidental perforation and prevent the vitreous seeds to come out and infiltrate the extraocular structures. Then long optic nerve stump has to be taken. Minimum 15 mm is advisable. Now, these enucleated eye will do histopathological examination for this enucleated eye to rule out if there is any anterior segment invasion, if there is ciliary body invasion, choroidal invasion, or optic nerve involvement beyond the lamina criprosa. So if any of these condition is present, adjuvant chemotherapy will required. So, and it has been noted, if in these condition, if you do not give adjuvant, the risk of METs will be 25%, and if you give the chemotherapy at the adjuvant, risk of MET will decrease to 4%. Then if there will be if there is full thickness scleral invasion or transected optic nerve involvement, you have to give the radiotherapy to treat the local extension. Coming to the differential diagnosis, there are 4 conditions whose lesions simulate the retinoblastoma lesion. First is Coats disease. So in Coats disease, rather than the leukocoria, you will see, as you can see in the first picture, you can see the golden yellow reflex that is known as xanthocoria in the Coats disease. And you will also see the partial or total retinal detachment with segmented dilatation of blood vessels and peripheral retinal telangiectasia. As you can see in this picture, first is of Coats disease, where you can see the segmented dilatation, and second picture is of retinoblastoma, where the entire retinal vessel is dilated. Then there will be the intraretinal subretinal exudation in the Coats disease, and on USG, you will see the exudative retinal detachment. Next is persistent hyperplastic primary vitreous. This condition will present since birth. The patient will have the relative microphthalmos, and you will see the Mittendorf dot, Bergmeister papillae, and you will also see the blood vessels attached to the posterior pole with persistent localized calcification, which will denote the persistent hyaloid vasculature. And on USG, you can see this fibrovascular band that is coming from the posterior lens capsule towards the optic nerve. Then in toxocariasis, first there will be the exposure to the cats in these patients. Then this toxocariasis is of 2 types, the peripheral type and the macular type. In the peripheral type, as you can see in the first picture, there will be the peripheral calcified lesion and fibrovascular fold that arise from the calcified lesion and goes towards the optic disc and give the traction over the lesion. And in the macular type, as you can see in the second image, there is calcified lesion at the macula with a dragged disc and blood vessel appearance. Then the last is retinal astrocytic hematoma. It is of 2 types, the non-calcified and calcified type. So in the non-calcified type, there is a lesion which obscuring the blood vessels. And in the calcified type, you will see the characteristic focal calcification. In retinoblastoma, we have the diffuse calcification, whereas in astrocytic hematoma, we have the fish egg type of focal calcification. Thank you.
Yes, good presentation. I think main thing we should all know are the differential diagnosis. And second thing is screening of siblings is also important. If there is any family history of retinoblastoma, as it is a genetically inherited disease, we have to screen the children as well as siblings.
Okay, sir.
What are the further screenings required after treatment of retinoblastoma? What is the usual frequency of screening afterwards? What are the risks of systemic malignancies in patients with retinoblastoma? Am I audible?
Sir, yes, sir. So 6%, sir.
6% is systemic malignancy.
Yes, sir.
What are the common malignancies associated with retinoblastoma?
Sir, osteosarcoma.
Yes, so that is also important. So we have to inform patient that if there are any other signs they find out, so they should not neglect and show to the physician immediately. Okay, any questions?
No, sir.
Okay, good
Sir,
presentation. Yeah.
what is the follow-up rate of these patients after the treatment?
So initially they have to be followed up every 3 months to check for the recurrence, and then later it can be gradually reduced, because even after treatment there is a small chance of recurrence of the disease. So once it is
Sir.
completely this thing, the remission is there are no mass lesions seen, then we have to follow up every 3 months, and we have to screen both the eyes and the peripheral fundus also in this patient. Okay, thank you. We'll end the session.